Thank you everyone for joining us. My name is Dr. Christopher Sipe. I am the Medical Director and President of Fertility Centers of Illinois, and I head up the Fertility Centers of Illinois COVID Task Force. And thank you for joining us. We have a great panel of local experts today. We've got Dr. Sam Ohlander from the University of Illinois Chicago, who is an assistant professor of urology. We've got Dr. Jennifer Hirshfeld, who is one of the physicians at FCI and a director of the River North IVF lab. We've got Dr. Kevin Madsen, who is maternal fetal medicine currently at DuPage Medical Group. And we've got Dr. Tiffany Edwards, who is a psychologist at the Fertility Centers of Illinois as well. As we know, as of October 20th, 2020, we're in the middle of a new pandemic. The pandemic is evolving in the medical knowledge that we have. One of the things that I have learned during this pandemic is you have to be adaptable and flexible, because what might come out one day suddenly is completely refuted the next day. Where one hospital may say you don't need gloves and gowns, suddenly a week later you're fired if you're not wearing gloves and gowns. So there are definitely lots of changes and things. It is an election year as well, so there are some political statements that are being made regarding the pandemic. We have to take everything that we read with grains of salt. So with this distinguished panel of folks that we have here, I'd like to start with Dr. Sam Ohlander to sort of give us a discussion about sperm and the urologic and male side of the COVID pandemic.
All right. So first off, I just want to say thank you for the opportunity to speak with all of you and kind of give the male input on things. So as Dr. Sipe kind of alluded to, all this is evolving. Up until probably an hour before this conference, there were presentations ongoing at ASRM that related to this topic. So new data being presented that's not even in publication yet. As kind of I'm going through things here, I'm going to talk a little bit about the pathophysiology and viremia, but then I'm going to get more so into clinically what we know and what we kind of don't know, and then talk a little bit about care recommendations from the male side of things. So, a lot of what we know about viruses, and for that matter, really anything that makes its way to the blood, depends on how it interacts with the blood-testis barrier. So testicular immune privilege normally protects the immunogenic germ cells from the host response. However, certain viruses are able to cross the blood-testis barrier, enter cells of the male reproductive tract, and elicit an immune response within the testicle. More than 27 viruses have been found in semen to date. Viruses like HIV, Zika, hepatitis, these things can be transmitted via the semen. So the concern is whether COVID may be able to as well. So if we look through the literature, what you find a lot of is, could COVID impact male fertility? We really don't have the data on if it does yet. So this is a hypothesis on how it could enter cells. I think the pathophysiology is important, but probably not as critical to this talk, so I won't get into too much depth here. Much of what is postulated about COVID-19 comes from what we know about the 2002 SARS virus, both of which are SARS coronaviruses. This work by Verma hypothesized cell entry. So similar to SARS, viral entry to target cells by COVID-19 is thought to be mediated by the interaction between viral spike protein and cellular angiotensin converting enzyme 2 and transmembrane serine protease 2. So ACE2 and TMPRSS2 expression occurs in many different organ systems, including the male genitourinary tract, although their expression seems relatively limited in the testes. With an opportunity for COVID to enter cells of the male genitourinary tract, there is a legitimate concern about viral transmission through sexual intercourse and the long-term male reproductive implications. Recent data by Pan et al. Using single-cell transcriptome data shown here suggests ACE2 RNA expression occurs at low levels in the testicle. These authors suggest ACE2-mediated viral entry of COVID into target host cells is unlikely to occur within the human testicle. Similar work by Stanley et al. Found that despite a small proportion of spermatogonial stem cells expressing ACE2 and TMPRSS2, cells co-expressing both genes were extremely rare. ACE2 has also shown expression in the prostate, but a recent study by Quanadel reported that 18 cases of COVID-positive patients did not have COVID-19 in mediated prostatic secretions. So far, no other study is available to validate whether or not the prostate is actually affected. So really, we need to investigate alternative biological mechanisms for alterations of the testicular microenvironment by COVID before any real conclusions can be made. Infectious and inflammatory conditions in the reproductive system are a major cause of male infertility. So viral infections may impair male fertility by directly affecting spermatozoon, inducing sperm death, reducing sperm count, and decreasing motility by inducing inflammatory cytokines. However, just as important, infections may also indirectly affect sperm production and function of the genital organs. While there's been theories on male reproductive pathogenesis, a lot of the leading theories suggest that this is an immune-mediated response to infection. So SARS had reported cases of severe orchitis, and we're starting to see some of that with COVID-19 as well. In a 2005 study of 8 post-mortem SARS patients, pathological examination of their testicles demonstrated germ cell destruction, widespread testicular leukocyte infiltration, and focal atrophy. However, SARS genome sequences or identifiable SARS viral RNA were not spotted in the infected testes, further suggesting that the impact of the testes was due to the immune response. A study from the University of Miami that was presented a little bit earlier this afternoon at ASRM found much of the same. There was a degree of inflammation and leukocyte infiltration, but not in all men. In this study, a bit different from the prior study, there was identification of viral particles on one patient via electron microscopy. The study suggests that SARS coronavirus caused orchitis and may lead to infertility even if they do not enter the seminiferous tubules, which I think is a question that is still without an answer. Temperatures could be an etiology of the pathogenesis. Persistent high fevers may negatively affect spermatogenesis and increase oxidative stress. This data here on the left is from a couple of decades ago at this point in time, but it outlines the heat impact of fevers. So semen samples were obtained and analyzed before 2 days of fever. In this situation, it was influenza. As you can see that there was a decline in semen parameters. However, there was a recovery by around day 79. And then lastly, it can be hypothesized that the association with testicular damage in COVID could be attributed to endocrine dysfunction as well. So if we're talking clinical data, recently there's been conflicting reports on the presence of COVID in the semen of patients who were previously diagnosed via oropharyngeal swab. The first report was published by Li et al. And JAMA Open Network. This study out of China identified 50 men that were reproductive age, of which 12 were unable to produce semen specimens due to ED, being in a comatose state or dying. I think that statement gives a little bit of insight into the population of the men that were being assessed in this study. For the most part, the population that they looked at were acutely ill patients. Ultimately, 6 of 38 tested positive for COVID-19 in the semen, 2 of which had clinically recovered, though as you can see, they had only recently recovered. While you'll see that the subsequent studies relate to individuals who had recovered, these findings do give me a bit concerned that perhaps in the acute phase, and maybe at high viral loads, such as patients that require hospitalization, presence within the semen may be possible. However, in such acute illnesses, contamination is a very realistic concern as well. I think that there remains a lot of questions after reviewing this study. The Li et al. Study was followed by a publication, Fertility and Sterility, by Jim Hotaling and colleagues. In this study, 34 Chinese men diagnosed with COVID-19 had their semen tested after a median 31 days of recovery. None tested positive. These patients had had mild to moderate symptoms, so a less severe disease than that of the prior study. The authors did note this in the study limitations, stating that it might be plausible that a certain viral threshold was not achieved across the blood testes barrier, but that this may occur with more severe disease. Of note, neither of these studies mentioned whether the virus was analyzed in washed spermatozoa, seminal plasma, or in neat semen samples. Assuming that was done in neat semen samples, its analysis in washed sperm remains kind of an attractive proposal, as the latter can guide the use in assisted reproduction. Holtman et al. Reported their series of 34 guys at University Hospital in Germany, including 18 men recovered from COVID infection and 2 men with acute COVID infection, and then 14 asymptomatic men as controls who were COVID antibody negative. They looked at men with mild symptoms, meaning those who managed symptoms at home, as well as men who required hospitalization and the use of oxygen up to 6 liters to maintain saturations. The virus was not detected in the semen of recovered or acutely infected men with COVID after a mean of 43 days after positive oropharyngeal swab. This finding is consistent with that prior PAN study. So unique to this study was the assessment of semen parameters. Albeit for the most part, parameters remained above the WHO reference range limits. There was a significant decrease in those with moderate disease, but not with mild disease. They further evaluated by whether fever was present or not, and found that those individuals who did have a fever demonstrated decreased parameters, but again, above the WHO reference range limits. So time will really tell if this is a sustained decline. For now, we just really have this snapshot at a short period after recovery. This year, this table kind of summarizes the studies that we have to date. It's primarily these 5. As you can see, it's really only that Lee study that has detected any evidence of the virus in semen. Everything else thereafter has not identified it. So moving on to the kind of the recommendations that we have at this point in time for care. Early in the pandemic, a joint committee of the Society of Male Reproduction and Urology, as well as the Society for the Study of Male Reproduction, came together to kind of address COVID male fertility related issues. And this committee focused on enhancing practice patterns. A primary point was that male reproductive consultations should continue via telehealth or other forms of remote two-way consultation. This has pretty much been universally accepted amongst male reproductive physicians, with the caveat that physical exam by a qualified professional is a key component of the men's health evaluation. So the guys that we're seeing, they don't regularly see doctors. Oftentimes the person that's referring them may not necessarily be somebody who is managing male reproductive care. So the physical examination, it hasn't always taken place. And so our evaluation oftentimes is the first evaluation that these guys have had. So it is very important that they be seen in clinic. Some are using scrotal ultrasounds as an adjunct. This is mostly for people who are traveling from far away. And so they can get a locally done ultrasound that gives a little bit of the information, but it doesn't necessarily replace the physical examination. The 2 slides or the 2 images that are on here is from a University of Michigan study that was presented at ASRM this week. And you can kind of see the real cost savings that are associated with telehealth in terms of miles, in terms of minutes, and in terms of money. So I think that at least from the male side of things, it likely has a place even after we get out of the pandemic. In lieu of the availability of fresh local semen analyses, home sperm testing can be utilized as basic screening test for male infertility as well. The committee felt that these tests did not preclude the need for evaluation by a urologist if conception did not ensue, including a fresh semen analysis at a local laboratory at some point in time. One example of kind of these home kits is the overnight mail kit that was developed at UIC. This has been in effect since 1996. This allows those who do not live in a region with access to cryopreservation capabilities to preserve future reproductive capacity. This service also offers semen analyses, so ultimately couples with potential male factor can obtain a semen analysis prior to traveling for reproductive services. And finally, sperm cryopreservation remains warranted for certain situations. I think here most reproductive services are moving forward. Our hope is that we won't fall back to restrictions on elective care. In certain cases, cryopreservation is warranted, particularly for those who are undergoing potentially spermatogenic treatment for malignancies and things along those lines. So these situations should be addressed on a case-by-case basis. And at this time, there's not been evidence that suggests that cross-contamination of specimens that are within storage. So with that, just wanted to say thank you again. This is my email address, so if there's questions that maybe pop up after the fact, you can always email me. If there's questions that you have with regards to general male reproductive care, feel free to email me, reach out. I'm happy to answer anything that you guys might have. Thanks a lot.
Sam, thank you very much for that talk. That was excellent. The blood testes barrier is something that's not really thought of very often, but it really is an important part of male reproduction. There were a couple questions that have been sent in during your talk, and I think you've answered them, but just to make sure. There have been articles about how COVID can render a man infertile. And I think you sort of said that's not really true except for the fever concept. Could you answer that question a little bit more directly?
Yeah, I think that there's the potential that it can impact fertility. So, right now we know that fevers can impact a guy's semen parameters. The hope is that after a time period, they get recovery. That study that I presented there from a couple of decades ago did show that guys, once they're kind of removed from that febrile event, do get a return of semen parameters. I think that part of our concern is this immunogenic response that guys might have, where there can be some destruction of the testicular tissue, similar to something along the lines of mumps, where if guys get that, it can impact their semen parameters. And at this point in time, we just don't know, because guys are presenting with orchitis with COVID. We just don't know if that's translating to impact on spermatogenesis.
Okay. And do those orchitis events seem to be caused by the COVID or some other etiology and event?
I think that at this point, the prevailing thought is yes, that they're related to COVID. I don't know that we necessarily have the data yet. That's one thing that I will say at the University of Miami. They are looking into quite a bit and trying to explore the pathology a little bit more, the histopathology, and trying to get evidence of viral particles, specifically in these guys that have orchitis, whether they're seeing it in the tissue.
Okay, that makes sense. Another question was, are cryobanks still taking sperm donations during COVID-19?
As far as I know, and I think that you guys can probably answer that as well. From my understanding and from our services, guys are screened, but they're still accepting, specimens, and we're still freezing specimens here.
Yeah, I mean, we're still doing it for their couples, but I guess I think the question is more directed at sort of anonymous sperm donors. I don't know that any of us can say exactly what some of the larger sperm banks are doing from a practicality standpoint. I would imagine any sperm that's collected would obviously be COVID tested prior to even doing that sperm donation, much like all anonymous sperm donors are for a variety of STDs and other diseases that can be transmitted via semen.
Yeah, that would be my assumption as well.
Okay. All right, perfect. Thank you so much.
Thank you.
We're going to move on to Dr. Jennifer Hirshfeld, who's going to discuss COVID in reproduction in women and then in the reproductive phase. Dr. Hirshfeld.
Thank you. Thank you. I'm so excited to be here. And thank you to everybody who's been a part of this and allowed us to hopefully share really good information. The first test is if I'll be able to share my slides. And I did. Okay.
Yeah. Technology is really impacting our lives in many, many ways now. Yes.
Oh my gosh, yes. So briefly, I'll be discussing a little bit of COVID-19 impacts fertility and pregnancy. We are lucky to have Dr. Madsen with us, who will do a much better job at some of the impacts of pregnancy, but sort of an overview. As Dr. Sipe mentioned, my name is Jenny Hirshfeld. I'm with FCI. So the goal briefly will be to go over overview of available COVID data, how it impacts pregnancy desire, which has been interesting, outcomes, and some of the mental health of both providers and staff, review some of the ACOG and ASRM guidelines, review some of the processes we put into place to make our clinic and our environment safer in the context of COVID, touch upon some of the research that we're a part of, particularly something called the ASPIRE study, to look better at COVID outcomes in pregnancy, and then to continue with the panel session where we really get to share best practices. So none of this is novel nor new anymore, but COVID-19 is a novel coronavirus. It's infected over 8 million US citizens. I created this slide initially a couple months ago in July as an overview, and that number was 3 million. So I think it just demonstrates that we're still really in the thick of this. The first US case was January 21st from travel. It is much clearer now that the travel is really not the main mode of spread, but direct patient-to-patient contact. As much as there's experienced a rapid increase in cases, hospital resources in some states, as we know, there truly are regional differences, are expressing and demonstrating some strain. The prevalence of disease continues to be disproportionately affect Latino and African Americans. There, as of recently, seem to be a greater amount of infections in younger individuals. And I think it's safe to say that the vaccine is still a ways off. Predominantly, we know that spread is related to close contact, respiratory droplets. Less clear about the real potential for physical environment touch. The 2 to 14 days of exposure to symptom onset. Unclear how predisposing factors impact outcomes. Some of the risk factors to be mindful of and some of the guidelines have included underlying medical conditions such as hypertension, diabetes, and chronic kidney disease, immunosuppressant use, and obesity, that it really is something that we have rethought of within our FCI patients. One thing that I think has been interesting has been sort of this desire of pregnancy to be impacted a little bit. And some of this is data that comes out of Time magazine that was from the Guttmacher Institute that really has shown that women to some degree are deciding to not have babies because of the pandemic. They argue that's bad for all of us for clear reasons in terms of emotional and mental health of the society. But I think if we dive into this further, what they demonstrated was 1/3 of women want to put on hold pregnancy or desire to have additional children. This question keeps coming up, and so looking at our own data, we've seen some reduction of new patients. We're really not seeing a reduction of care. The question is, this is a reflection of backlog. Other REI practices are quoting some of this similar diminishment. I think this is something that probably is going to ebb and flow as things become more or less predictable in COVID by regions. But this desire to be pregnant, there's no question this is multifactorial. This is just something that's observed and to be aware of. What is the data of COVID in pregnancy? Really briefly, overall, the data is felt to be relatively reassuring for full-term deliveries. There's been some possible increase in preterm labor. Data suggests that pregnancy increases the risk of mechanical ventilation and ICU admission, but not mortality. So again, being pregnant compared to not being pregnant put a woman at a higher risk of these incidents, but not of death. So that is still important as we think about this. Of course, nobody wants to be admitted or intubated, but it's something to keep in mind. These facts were especially true within African American and Latino populations. There was some suggestion within the data that this is a marker of socioeconomic status. All of this, without question, is still being delineated. There was a meta-analysis that suggested potential increase of preeclampsia and C-section rates. Some of the comorbidities such as hypertension, diabetes, and obesity within our pregnant and fertility patients is really important as we think about COVID-19 risks. In this context, as a clinic, we have changed our BMI marker, our number of which we no longer provide treatment. So we usually had utilized 50, a BMI above 50, we had declined fertility treatment. We have pushed that number to 45. And this is really looking at CDC and other guidelines about what is independently increasing people's risk of complications of COVID. So before we take on pregnancy, and in our context, exposure risk by coming to our clinic, despite all our efforts, anytime you leave your home, there is that increased risk. We want to make sure we're minimizing everything we can to have as healthy as possible if, God forbid, someone gets COVID. I think really what is also interesting is what is the data of COVID and pregnancy in terms of how it is emotionally impacted. I think this is things that ACOG has done a really great job if you look at their website. This is data from one meta-analysis, looked at 62 studies, 160,000 individuals, both patients and providers. And what they identified was that they're within the prevalence of all comers. There was about 33% of anxiety and 28% of depression within the populations that were sought and interviewed. And those numbers increased quite a bit for those who had risk factors or actually had COVID. So 1/3 of the population to be experiencing depression and anxiety is no small number. And I look forward to hearing more of this from Dr. Edwards. ACOG really is focusing on emotional distress of providers from the very beginning of the pandemic to now. So how do we minimize that? By encouraging routines and managing news consumption and staying connected. How do we within our clinics and as our staff continue to do self-care and other ways to minimize the emotional distress? Within FCI, we had been offering both group and continue to individual sessions within our behavioral health staff. So what is the data in terms of vertical transmission? And so there's been some case reports that suggest possible vertical transmission, but this is, if anything, felt to be rare and uncommon. There was the placenta study out of Northwestern that there was some potential that there's a vascularity seen in those with COVID, but not. But this is very, very investigational. As of now, the American Academy of Pediatrics continues to recommend breastfeeding in women with active COVID disease. If we look then, so what is ACOG telling us for resumption of comprehensive care? They're really encouraging in their guidelines to use a data-driven approach. What is your local level? What is your state prevalence? To incorporate testing, and incorporate testing means it has to be widely available. To encourage physical distancing within your clinic, to maximize telehealth. I know within FCI, we have really taken this to heart. We are utilizing telehealth for really all consultations, all visits with the exception of procedures. How do we assure that PPE is an adequate supply? And then they provided really excellent specific, which I'm sure many of you in this audience already know, recommendations for OBGYN, and here's that website for all different situations. ASRM has continued to provide guidance at least every 2 to 4 weeks. Their most recent one came out in October 12th, where they had made some recommendations of encouraging the flu immunization for all healthcare providers, and that we strongly encourage this for patients, given again the similarity of symptoms, the concern that flu could be worse. This is without a question always important for pregnant women to get a flu vaccine, but coming out encouraging those of us that take care of pregnant women as well. They highlighted also, like ACOG, the regional differences within the US that may recreate restrictions, and that certain locales in crisis may have different approaches to those that are not. And so it is hard to make blanket statements throughout the country when there's very different experiences. They had suggested that surveillance testing does not constitute prevention, which we all know. So even though if you're screening our patients for COVID, that doesn't mean we cannot be doing all the things we're all doing, which is utilization of PPE, masks, hand washing, social distancing. And they went into a lot of detail about how you can incorporate, if you have access to it, point of care or rapid testing. Their guidelines, the website is there. So I think within FCI, this is something that has been evolving for us, but how do we manage our positive COVID cases, whether it's our patients or it's our staff? The CDC had outlined both what they call symptoms and test-based. Asymptomatic and less ill patients, it is now universally recommended to use symptoms-based. This is a busy slide, but duration of isolation and precaution for patients with COVID-19, the thought is that after 10 days from symptom onset or within 24 hours of resolution of the fever, they can again sort of return to society. For patients who never developed symptoms, they were almost an asymptomatic positive 10 days after that first positive. But in both of these cases, they are no longer advocating that you test again. The role of PCR testing to stop isolation has really been restricted to immunocompromised. And some of this is the concern that these tests can maintain positivity for almost 3 months. And so what's difference between positivity of a test and that you're contagious are felt to be two different things. What about the role of PCR testing in terms of discontinuation of isolation? So again, one of the things that they address, which is interesting, is for patients that were previously diagnosed with symptomatic COVID who remain asymptomatic, and then within 3 months, they're again having symptoms. And so what they kind of outline is that with the new initial symptoms, it's theoretically a second exposure, and that these are the cases that there could be assistance with infectious disease physicians. Again, for those who never develop symptoms, that they use that first positive test as symptom onset. So then 10 days from that first positive test before they can sort of return to society. And the serological test, so the antibody testing, as of now, CDC does not feel that it has a utility. So what have we done at FCI? So here have been some of our policies and put into place from the beginning. This is something we're constantly reviewing. This again sounds even silly to describe now in the world we're in, but we require face masks for our staff and patients, which is definitely the way that things are overall within the world, that we are providing opportunities for our staff to work at home when feasible. And again, the goal of this is multifactorial. This is to empty our space, so to speak, so we can truly socially distance, is to get members of our staff not physically there and at home. There's potentially the benefit of emotional well-being if you're able to be at home. There's the stress that many of our staff, like many of your staff, is facing, as they have other responsibilities with at-home school learning and other factors. We've really taken ACOG and ASRM guidelines to heart, and we're encouraging telehealth, again, to minimize those in our office. We've encouraged and increased our additional cleaning strategies of our high-touch surfaces and equipment, things like ultrasound. We are distancing in all offices. As I say to patients, we have exchanged convenience for safety. So where we would pride ourselves on getting as many patients in at that 6:30 a.m. slot, that is just not feasible in a COVID world. It really is necessary to make sure that there's space so that it's safe. As of now, we are not allowing partners, family, spouses for appointments or procedures, which means yes, that patients like an embryo transfer is being experienced without anyone present in the room, but we are incorporating FaceTime. The rationale, again, simply being less patients within the space, less individuals to help it be safer. We are utilizing the CDC symptom approach for those patients and staff who are identified as COVID positive. We are screening all of our patients undergoing treatment. So in the context of screening is when we're identifying asymptomatic patients. Those with symptoms of fever, a sore throat, they are discouraged from coming to the office. They're encouraged to follow up with their primary care physician. How we're using symptom approach, again, really for our patients is really those that we asymptomatically identify in the context of their testing. And I think what's really important is we're really trying to make efforts to provide emotional support because we know how draining this has been, both to our patients and to our providers and our staff. So we at FCI are part of UCSF's Aspire study, which is really kind of awesome. It's a relatively straightforward study for patients to enter across the US so that we're able to learn more about how does COVID really impact pregnancy. So they're assessing the safety of pregnancy in the corona pandemic. The way that we enter is that we encourage patients to apply. We're giving them information, all of their ultrasounds and first pregnancy tests. It is relatively straightforward. It's an online questionnaire. Their symptom screen. They do a finger prick at the end of each trimester. That is something that a patient will learn if they opt to do this. I think what is exciting is that we are proactively, as part of a larger community, asking these questions so that we have more data to tell our patients and to share about how does COVID impact pregnancy? How does it impact miscarriage rate? None of us know right now, but the goal of this type of study is to help get to those answers. So if any of you or patients are interested, please look up that website right there. You can send any patient. They do a great job of helping patients to enroll if they're interested. So with that, thank you so much to everybody, and I'm so excited to be a part of this. I currently am at our River North and Highland Park location, although we can Zoom from anywhere, so I guess that seems even silly to mention that. I'm Zooming from home. That is my Instagram, and that's my email, so please email or call or however we can best answer your questions.
Dr. Hirshfeld, thank you so very much. That was excellent. A couple questions that were sent by different folks. What are the current options for women considering artificial inseminations? So
same as pre-COVID. So we are utilizing artificial insemination. We're doing all of our treatments. We are not holding any. So when women are doing IUI or artificial insemination, initially before we jump into treatment, we'll ask you to do a visit with us. We'll do some testing to get to the cause of infertility. If artificial insemination or IUI is felt to be helpful, the one thing we will be doing is we'll be screening you before you start within 2 weeks of when your IUI would be, or identify again that individual with asymptomatic COVID, so then you don't achieve pregnancy. We will be asking the partners to create specimens at home and drop it off at our facility, simply to minimize who's in the space. But besides, and the IUI would be done without a partner or a spouse in the room with you. So those are the slight differences. I like sort of the COVID approach, but the absolute treatment and the way we go about it really hasn't changed.
Excellent. Another more specific question is, how has surrogacy been and continue to be impacted by COVID-19?
That is a great question, because that is continually changing. I think some of the challenges that we have is in regional differences. So when there's a prevalence of regional differences, patients or gestational carriers who are coming, we are screening in a more frequent way. Instead of just simply within 2 weeks of achieving pregnancy, we're screening both when they come and prior to the treatment. I think some of the challenges are not only the gestational carriers, but some of our patients who live out of state. Some of the restrictions when they come into Chicago based on where they live, if they live in one of those states that is asking you to quarantine for 2 weeks. I think the travel piece has created more hangups. Again, utilizing telemedicine or telehealth or FaceTime are different ways that people are being a part of the process without physically have to come here. So we are utilizing gestational carriers for pregnancy. That has not stopped. How they're being monitored, though, is different. How patients are being able to, or gestational carriers are able to come from different states has changed a bit. So it reinforces potentially the value of identifying a gestational carrier within Illinois.
There's some studies from months ago, probably feels like years ago, although it's only a few months ago, about people who did surrogacy, international couples who would come to the United States, use an American surrogate because it's legal in this country and illegal in theirs. Their child was born to the surrogate, but due to travel restrictions across all countries, they've been unable to have their child, quote unquote, be delivered to them physically. And so those restrictions continue. I think most of the surrogacy and egg donation cycles that we're doing right now are not international, but all in US based and primarily Chicago based. But we are utilizing, international or national egg donors and surrogates. It is an area of reproductive medicine that does have some oversight by the FDA. There are some criteria that have to be followed. And in general, for most of the infertility treatment options, it's the area that has the most restrictions by governmental agencies and things. So they have not come out and said anything specific about not doing it, but they've been pretty suggestive of making sure that testing happens on a fairly regular basis. So I know at FCI, those are the policies we've been following. But thank you very much, Dr. Hirshfeld. I appreciate it.
Thank you.
All right, Dr. Madsen, we would love to hear how to manage pregnancy in COVID, sir. So please tell us what to do.
I wish I had all those answers. Let me switch on my presentation here, if I may. Thanks again so much for allowing me to participate in the forum. As Dr. Sipe pointed out, the day-to-day changes here are impressive, to say the least. And I think when it comes to management in pregnancy, however, we have growing experience, and I hope to, in the end, I have some more recent literature that's just been published that really seems to drill down to some themes that appear a little bit more consistent. And I hope as a result, this can provide more consistent recommendations and advice for our patients. So in order to discuss this hot topic, I'm sure all of you as well have spoken about COVID-19 in your various disciplines to your providers. And I too have done many talks in this regard, but I will want to briefly give you some background on COVID-19, talk about some current epidemiologic data. We'll discuss clinical characteristics of COVID-19 in pregnancy, some other clinical considerations, and then I'll drill down to some recent literature. So background, this is overlapping some of the things that have already been discussed, but we know that pregnant women are often disproportionately affected by respiratory illness from our influenza experience. And as a result, there's higher than expected morbidity, as well as higher mortality rates. Hence, when the pandemic began, we had great concerns. Most human coronavirus infections, as you know, are mild. And epidemics of the past 2 decades, including SARS and MERS, however, were associated with grave, very high maternal mortality rates. COVID-19, as you're aware, is caused by the severe acute respiratory syndrome coronavirus 2. And on March 11th, WHO declared the pandemic. So this is a novel enveloped RNA beta coronavirus. And it affects the host respiratory cells through the angiotensin converting enzyme 2, or the ACE2 receptor. And this is predominantly in type 2 alveolar sites. However, it's present in upper and lower respiratory sites. So you can see symptoms both in the upper and lower respiratory tract. There does appear in some epidemiologic studies to show some sexual dimorphism. And since there appear to be more COVID-19 infections in men than women, Some cellular studies have suggested attenuation of ACE2 receptors in women. The mean incubation period of SARS-CoV-2 is felt to be approximately 5 days, but ranges anywhere from 2 to 14 days. And viral shedding, as Dr. Hirshfeld alluded to, can persist the mean 40 days of RNA viral shedding, but we've seen patients up to 37 days, some even longer. How infectious is it? When we look at the R0, the basic reproductive number, how many people on average each infected person will in turn infect in the fully susceptible population, we know it's COVID-19 more infectious than seasonal influenza, but not as much as SARS or measles. Let's look at some data. And this is, again, data I downloaded. This is the dashboard I like to look at regularly from the Johns Hopkins University, their Center for Systems Science and Engineering. It's a quite robust dashboard with immense data points. You can drill down in many, many ways. This is downloaded as of yesterday evening, 40 million worldwide cases, 40,334,000. While we were speaking here, I did quickly look. We're up to 40,632,000, again, emphasizing the rapid nature with which this is expanding. Over 8 million cases in the US, and as you're well aware, over 220,000 deaths, with over 1 million deaths globally. Again, as we've seen, at least 368 new coronavirus deaths and over 47,000 new cases were reported this Monday, the 18th. And over the past week, there have been an average of over 56,000 cases a day. This represents a 30% increase over 2 weeks earlier. So we are seeing the so-called another surge here. Kind of a map of coronavirus infections per capita nationally. I think we've heard this often talked about in waves. I think a better description I've heard is really more a wave that's sloshing through a pond. So in other words, we're seeing the effect of repetitive sloshing of this virus, the novel virus that it is, now investing itself into more rural areas who are not immune to COVID-19 infections. Regionally in Illinois, over 9,000 deaths and over just under 350,000 cases. Clearly case clusters initially in the more heavily populated areas, but now you see investing itself into rural areas of our state as well. What about clinical characteristics of disease? Acute respiratory distress among 17 to 29% of hospitalized patients was reported, as well as abnormal, this is among hospitalized patients. Chest x-rays are virtually almost always abnormal amongst hospitalized patients, but lymphopenia, leukopenia, and thrombocytopenia are noted. And this is important for us practicing obstetricians because we think HELP syndrome, and we often don't want to lose track of that when we have patients who have what might seem to be atypical HELP in the context of a pandemic. We're going to screen that patient, although we are screening all of our patients when they're presenting to our hospitals. The cardiorespiratory and immune system changes in pregnancy can increase susceptibility to severe infections as well as hypoxic compromise. In pregnancy, there can be delayed diagnosis. Why? Some of the physiologic changes of pregnancy can make this challenging. Sore throat and nasal congestion are present in about 5% of patients with COVID-19. But gestational rhinitis, or the so-called nasal congestion of pregnancy, is present in 20%. Shortness of breath, present in, on average, 18% of COVID-19 patients, but physiologic dyspnea of pregnancy is present in 70% of pregnant patients. Again, any of these symptoms currently, particularly with recent case surges, are going to allow us to have a relatively low threshold for testing. Further, the altered respiratory and pulmonary volumes in pregnancy can more readily predispose women to hypoxic respiratory failure. Diagnosis, as you're well aware, the gold standard is the reverse transcriptase polymerase chain reaction test. These are unfortunately now much more readily available. Most commercial assays are going to give us qualitative results. Important to recognize that false negative results are possible with particularly low viral loads. Antibody detection improved and much more readily available. Its utility is somewhat unclear at this point. Viral cultures aren't considered practical. imaging in patients who have chest x-rays, peripheral aerospace shadowing is what's noted. On CT scan, multi-lobar ground glass opacities or consolidation can be seen here. As a practicing maternal fetal medicine physician, we always want to emphasize to our practicing obstetricians and providers that if imaging is felt to be necessary on a clinical basis, we certainly don't want to withhold it on the basis of pregnancy alone. Now, when we look at maternal morbidity and mortality, fortunately, much lower for COVID-19 compared to SARS and MERS. However, maternal mortality has been reported with progressive respiratory failure and severe sepsis. Some other clinical considerations, the so-called COVID-19 severity scale is often utilized, and we have really 5 categories. So the asymptomatic, pre-symptomatic, or what I often like to refer to as oligosymptomatic. So you'll drill down and talk to a lot of women who might have an incidental positive, perhaps from an exposure, or they were screened at a healthcare provider. When you drill down, you'll find that those patients often do have minor symptoms. They might not have drawn their attention, but they might be there. But they have otherwise no other significant symptoms. Mild disease fortunately affects the majority of patients with COVID-19 in pregnancy with flu-like symptoms, fever, myalgias, anosmia. Moderate disease is where we can have evidence of lower respiratory tract infection, but still maintaining oxygen saturations. Severe disease is where we're going to start to see lower respiratory tract involvement, patients with significant respiratory symptoms, tachypnea, hypoxemia. And then critical disease is where we will see multi-organ failure, dysfunction, shock, respiratory failure requiring mechanical ventilation or high-flow nasal cannula oxygen. Generally, we manage our patients. We've managed several with COVID-19 in pregnancy as an outpatient. We advise those patients to self-quarantine. And again, fortunately, most are asymptomatic or have mild disease. We advocate for close obstetric monitoring for worsening symptoms. Patients are to perform self-daily assessments and to contact the health team for any concerns regarding progression to severe disease. And here, telehealth serves a great role at providing care and observation of our patients. Reasons to call the healthcare team: worsening respiratory symptoms, tachypnea, unremitting fever, inability to tolerate oral hydration, persistent pleuritic chest pain, confusion, lethargy, or cyanosis. OB complications to monitor are those that we always look for: preterm contractions, vaginal bleeding, or decreased fetal movement. There's no guidance from the Society for Maternal Fetal Medicine about the frequency or timing of outpatient visits. We do advise amongst our providers to have a follow-up visit at least once within 2 weeks of the COVID-19 diagnosis. Again, generally this would be via telehealth. We do have, in our group at DuPage Medical Group, we've designated so-called red sites. These are designated sites to care for patients with COVID-19. We have this for all of our primary care providers, but we also have a designated obstetric red site. There's a very specialized workflow in these sites. Patients are seen clearly one at a time. We have multiple staff members there. We do have the advantage of having full PPE. Patients are kept in their automobiles until we are ready for their visit. Doors are held open for them. Surfaces are cleansed between visits. We have separate ultrasound equipment there. Again, fortunately, we haven't had to see many patients because most, again, can be managed in the outpatient setting alone, at home, on quarantine. But for those that require care, we do have safe mechanisms to provide care for pregnant women. But as a result, we had some concerns about OB providers being actively involved in patients' care, even for those that are at home. Do women with COVID-19 need antenatal surveillance? It's unclear. There really is no definitive evidence of fetal transmission. I'll talk about that with some other data shortly. And antenatal surveillance is generally per usual obstetric protocols. Now, there's still some confusion in the literature about this regarding some placental studies, as well as some stillbirths that have been reported in the literature. However, most stillbirths have been reported in the context of mothers who have had critical illness with multi-organ dysfunction. So we don't currently view this as an independent need for antenatal fetal surveillance. Preterm labor, many studies have reported increased preterm birth risk. However, most of these are increased iatrogenic preterm births, not spontaneous preterm births. Again, systemic severe illness does increase preterm birth risk. Of patients who are delivering preterm, we will often use magnesium sulfate for fetal neuroprotection. Here, in a woman with an active respiratory illness, we might be somewhat more limited in its use. Are there delivery considerations? COVID-19 is not an indication for delivery, and in fact, when we have patients who recently screened positive at or around the time of delivery, we may attempt to delay her, if there's a planned delivery, delay that delivery until quarantine is lifted, as long as there are no other medical indications for delivery. Preterm delivery is always considered in critically ill women, but only if it's felt to improve maternal status. Again, beware of the overlap with HELLP syndrome, but preeclampsia doesn't appear to be of increased risk. We do remind providers to watch for that transaminitis and thrombocytopenia that it could represent an underlying SARS-CoV-2 infection. Corticosteroid use, we would use this as we customarily would for women at risk of a preterm birth less than 34 weeks. Currently, we may advocate use of steroids in other contexts in the late preterm status of a woman who has an active COVID-19 infection. Due to some concerns of steroid use, we may limit its use in the late preterm window, since maternal benefits likely of steroid avoidance likely outweigh the limited neonatal benefits. I want to talk about some recent literature. These are some studies that have just been published that I think are relevant to summarizing the current state of the data today. This was published in the New England Journal, in the British Medical Journal, about how does pregnancy affect the clinical profile of COVID-19. So this was a meta-analysis of 77 studies with over 8,000 pregnant women with COVID-19. Reflecting routine testing during hospital admission, 10% of pregnant women were diagnosed with COVID-19. And they were compared to non-pregnant women, pregnant women with COVID-19 were more likely to have ICU admission. As Dr. Hirshfeld had pointed out, the odds ratio was 1.6, as well as mechanical ventilation, and less likely to demonstrate symptoms of fever or myalgia. Here, this was useful because there was a CDC published a morbidity and mortality weekly review that alluded to these similar trends of ICU admission and mechanical ventilation. So having that validation from this large meta-analysis likely means that it may indeed be true. Mortality, as other studies have shown, is low at 0.1%, fortunately. Risk factors for severe COVID-19 that were identified are the ones that were already discussed: obesity, hypertension, diabetes, and advancing maternal age. Spontaneous preterm birth was not elevated, and this was helpful to tease that out, as so many of the studies have lumped together iatrogenic as well as spontaneous preterm births. NICU admission rates were high at as much as 25%. Some of that may be reflective of protocols that were utilized amongst NICUs when neonates were delivered of known COVID-19 positive moms. So COVID-19 does appear to have a more severe course in pregnancy with higher ICU admission rates and higher mechanical ventilation rates. However, the same pre-existing conditions that exacerbate severe COVID outside of pregnancy are associated with severe outcomes during pregnancy. Now, moving on to infant outcomes following maternal SARS-CoV-2 infection, again, published in late September. This is a registry report, the first report from this registry, the Priority Registry, which is the Pregnancy Coronavirus Outcomes Registry, also at the University of California, San Francisco. And pregnant women with suspected or confirmed SARS-CoV-2 infection were reported. And this was an interim analysis of early infant outcomes. So 263 infants were reported on through, this is through a report through June 22nd. And of those, 179 infants were born of women who had positive SARS-CoV-2 testing, and 84 were moms who were negative for SARS-CoV-2. There was no difference in NICU and respiratory morbidity between both groups. Infants of mothers who tested positive within 14 days prior to delivery did appear to deliver a bit earlier than those who had tested positive greater than 14 days prior to delivery, but the difference was negligible. Both were term, 37 weeks versus 39 weeks. There was no difference in congenital anomalies in the groups, and only a relatively low risk of positive infant SARS-CoV-2 testing, only 1%. 6 to 8 weeks after delivery, a nice outcome that was important to note. None of the infants had pneumonia, and there were similar rates of upper respiratory tract infections in both groups. So the overall findings regarding infant health are relatively reassuring. Further investigation with longer follow-up, larger sample size, and a broader demographic representation are warranted. It was noted in the priority registry that there's a disproportionate representation of Caucasian women and an underrepresentation of women of color. This is not uncommon in many studies, but clearly doesn't represent the breadth of this disease as well as higher risk demographic groups. Let's talk about, this is another meta-analysis of rates of maternal and perinatal mortality, vertical transmission in pregnancies complicated by SARS-CoV-2 infection. This was a review from the start of the pandemic until mid-April. And there were 13 eligible articles, each with greater than or equal to 10 women with confirmed COVID-19. There was a disproportionate representation, as it was early in the pandemic, with literature from China, with 342 out of the 435 deliveries noted. But looking at their results, ICU admission was hovering around 3%, critical disease 1.4%, and no maternal deaths. And I think that's the thing we focus on, fortunately, the most. Preterm birth rates were high at 20%, keeping in mind the worldwide rate is about 10 to 11%. The Chinese experience early in the pandemic led to iatrogenic preterm births, and they were reported to be just for COVID-19 alone. Similarly, the cesarean section rate is astoundingly high, but here too, the Chinese data, the majority, the C-section rates in some of the Chinese data was well over 90%. There too, COVID-19 alone was felt to be an indication. And some of this is with an evolving pandemic. They were early in the course. It was unclear whether vertical transmission was prevalent, and whether cesarean section might be protective. Clearly, that's changed now. Vertical transmission was 0% in this study, and neonatal death rates were low. So reassuring low rates of maternal and neonatal mortality, as well as vertical transmission, high cesarean section and preterm birth rates, but likely related to geographic practice patterns. Finally, something interesting I came across, this was a perspective piece in the New England Journal that I thought was particularly relevant to a discussion in a fertility forum. And it involved a really nice discussion of the concept of delaying pregnancy during a public health crisis. So we have history here with pregnancy avoidance and advocating pregnancy avoidance with the HIV epidemic, H1N1, Zika, and now with COVID-19. So the first experience here was really with HIV in the 90s. We knew that there were poor outcomes amongst perinatally infected children and mothers. And the CDC, in fact, initially advised delaying pregnancy. This raised many ethical concerns involving moral censure of women, coercive policies, constraints on reproductive autonomy, a very sensitive ethical issue, and really just frank discrimination. In 1996, a multidisciplinary working group was convened, and they developed the concept of so-called contextualized counseling. And it was concluded that one could not rule out a thoughtful decision to proceed with pregnancy, but acknowledging risks of untreated HIV for women and their offspring. H1N1 in the late 2000s, also very concerning regarding significant risk for maternal mortality with H1N1. And as a result, there was pressure on the CDC to advise about pregnancy delay. As an alternative, however, the CDC focused on methods to prevent infection and the importance of early treatment and vaccination. Then we had Zika in 2016, 2017. Again, pressure to advise delay of pregnancy, particularly in areas of transmission. Here too, the CDC advised a different approach rather, to discuss risks in pregnancy, review ways to avoid transmission, and then to discuss reproductive life plans rather than making an absolute recommendation against pregnancy. What about now with COVID-19? Well, Delaying conception, again, has been discussed. And as you alluded to in your data, some people are doing that on their own. But the pressure on public health officials to do it is pretty immense, particularly in the beginning. So as we've talked about, there is limited data, but we have a more consistent body of evidence to suggest that there are maternal risks. Unfortunately, no marked increased risk of maternal death. But fortunately, the fetal risks appear to be relatively low. Vertical transmission felt to be unlikely, and again, no apparent increased risk of anomalies, and no apparent increased risk of spontaneous preterm birth. So what about pregnancy avoidance and discussion about it? Well, generally, as in many areas in medicine, we take a non-directive approach here, where we discuss risks with patients and we talk about how to minimize them. And then we support the patient in her and her family making an informed decision. Occasionally, we're going to utilize a more directive approach. And this might be in instances where severe maternal risk might be associated with pregnancy. This would be a patient with Marfan's disease with a dilated aortic root. We're going to be a lot more directive in advising strongly against pregnancy in that context. So before public health officials advise pregnancy avoidance, there's some important things to outline, just some guidelines that one would utilize in this context. First of all, the risks should be well understood. Here, early in the pandemic, even currently, we have an evolving understanding of the risks, but we really don't have a full understanding of what the risks of a new pathogen are. A contrasting example might be if we had a large public release of radiation, for instance. There, that would be different. The risks there are fairly well delineated and high, so that might be an instance where it would be appropriate to strongly advise pregnancy avoidance. If we were to advocate for pregnancy avoidance, again, risks should be high, but well above those risks associated with other conditions that are fairly common amongst pregnant women. An example here, we don't routinely advise against pregnancy amongst our diabetic patients, despite knowing that they can have potentially high risks of fetal anomalies, prematurity, miscarriage, as well as maternal risks of worsening retinopathy, worsening nephropathy. We try to manage those disease states. We would avoid it where risks can't be minimized or mitigated. So if we had no way to minimize or mitigate risk of an infectious issue, we may suggest pregnancy avoidance. Other public health guidance, always effective contraception should be readily available for those who do choose to do it on their own accord. And of course, educational programming to help educate the public regarding these matters. So the other issue, when we talk, the pandemic raises this very important question about a public health official recommending deferring or avoiding pregnancy. And it really does raise those ethical concerns regarding reproductive autonomy. And as a result, strong justification is needed. COVID-19 really doesn't meet the bar in this regard for all the reasons that I've outlined. But we do want to provide information and support to women related to their reproductive decision. So summarizing, there's no evidence that COVID-19 in pregnancy increases risk for maternal mortality, vertical transmission to the neonate, fetal anomalies, spontaneous preterm birth, neonatal respiratory morbidity, or fetal death. Some evidence suggests that COVID-19 in pregnancy increases risk for maternal ICU admission and maternal mechanical ventilation. Anecdotal experience, pregnant women are as likely as the general public to get to the disease. Pregnancy doesn't place a woman at an independently elevated risk. Symptoms, fortunately, are likely to be mild to moderate. However, as you're well aware, severe symptoms have been reported in pregnant women. And the COVID-19 pandemic is not a contraindication for pregnancy planning alone. Finally, as we've all talked about, most of this is based on consensus and best practice, and the data is constantly evolving, hence the need for us all to keep up and share our best practices. Thanks a lot. There's my email address, certainly if anyone has any questions.
Dr. Madsen, thank you for such a very thorough and thoughtful discussion on the coronavirus. That was excellent. Really looking at a lot of the different angles from the maternal risk to the fetal risk and to the transmission possibilities. That was very enlightening, so thank you.
Thank you.
Couple emailed questions. We'll get to the vaccine. There's a bunch of ones on vaccine, which we can sort of get to a little bit later. What should someone do if they become pregnant and are diagnosed with COVID-19?
Sure. So I think, again, we would talk about the very basic recommendations about self-isolation, monitoring symptoms. That's going to be the most important. Even in women with some of the potential morbidities we talked about or comorbidities at risk for severe disease, most, as you all know, I mean, pregnancy generally selects for people who are relatively healthy. So fortunately, most women are going to do well. But we don't make any other special recommendations other than monitoring for disease. As far as pregnancy management is concerned moving forward, in the absence of further clear-cut recommendations and because of the evolving nature of the pandemic, most have advocated, as we do, for an anatomic survey if the patient contracts COVID early in the course of a pregnancy, a so-called level 2 ultrasound. And then we always advise at least one growth ultrasound later, at least in the mid-third trimester. One thing I didn't touch on in the presentation, but I think is relevant, is the potential risk for venous thromboembolism. This is another complex issue where we have no clear-cut guidelines, and a lot of this is just by consensus and expert opinion. We do know that from the non-pregnant data that appears that COVID-19 infection does pose a thrombotic risk, and there is the placental data that Dr. Hirshfeld alluded to regarding placental thromboses from that Northwestern placental study. We also know, of course, that pregnancy poses an independent thrombotic risk. So people are all over the map. And I'll be honest, when I was helping develop some of the protocols for us at DuPage Medical Group, as well as the hospitals where I practice at Edward and Elmhurst Hospital, this was the final barrier, the one that I was the most stuck on, because I couldn't find, there's number one, no evidence, and I couldn't find great expert opinion on it. So I did what most of us do, is I tried to delve deeper into the literature, and then I reached out to some professionals that I respect in hematology. And I had a very thoughtful discussion with one of our hematology colleagues. And what we've advocated for is a short course of thromboprophylaxis for all patients after infection for a period of 4 weeks. If a woman has an infection at or around the time of delivery, then we would continue that thromboprophylaxis through the puerperium for 6 weeks postpartum, because those risks for thrombotic events would be higher. Again, that's the one that's probably going to change the most, but our thoughts were from a risk-benefit perspective. We felt that a low dose of a thromboprophylactic dose would be relatively not that morbid, particularly for a short term, and with some potential benefit. Obviously, this is we call for a shared decision-making process with our patients when we discuss that with them. Specifically, we have to individualize that. So if I have a patient in the first trimester where that risk might not be as great and she has a subchorionic hematoma and she's bleeding, we might make a decision to say, hey, maybe it's not the best choice for you in this instance. And conversely, if we have patients who have other risk factors for venous thromboembolism or other thrombophilias, those patients might need even significantly higher doses of anticoagulant. And those are the folks that we generally are going to want to consult with our hematology colleagues.
Yeah, that is an excellent point, because I think as management of these hospitalized COVID patients expanded in the United States in February, March, and April, we started seeing a whole lot more blood clots than what had been previously reported. And it seemed like there was much more vasculitis or vascular pathology associated with this virus than compared with other SARS viruses. So that's been interesting. In fact, if you look at the data from the number of hospital admissions early on, everyone went to the ICU and was ventilated. And now people are trying to avoid going to ventilation status because they think they're getting secondary infections and leading to blood clots with the immobilization. So there's really been a huge difference in how we manage these patients.
Absolutely. And I think some of those comorbid risk factors that we see for worse outcomes are probably related to vascular aspects of the disease. Obesity is a great example. When you have endothelial activation in obese patients, is that why we might see more morbid outcomes in those patients, perhaps? But I think I agree with you. I think the vascular aspect of the disease is the one that's quite concerning, but certainly evolving quite a bit as well.
Yeah. Excellent. Thank you. Well, Dr. Edwards, we're going to get to you now. And, you know, the amazing part of COVID was early on, I kept hearing about the COVID triad, which was, hey, I'm stuck at home with my wife. I'm going to have a lot more sex, nothing else to do. So I'm just going to start drinking. And then I'm going to suddenly gain like 20 pounds. And that seemed to be sort of the running joke around everyone, you know, early on in the pandemic. And now we're sort of stuck with this pandemic fatigue syndrome. Whether it's a syndrome that's been classified or not, it's a different story, but it's all over the internet and all what anyone can talk about. And it's partly being blamed for this rise in these secondary spikes that we're seeing, is everyone sort of got relaxed with the pandemic. And it's amazing because that's really, if it's fatigue, that's really all psychological. So with that lead in, I'm going to have you solve our nation's problems and tell us how we can get rid of the fatigue and start practicing a little bit better social distancing.
I hope that I can live up to those expectations. My name is Tiffany Edwards, and I'm the clinical psychologist with FCI, and I'm going to be talking about the psychological and the emotional impact of the COVID-19 pandemic. Next slide. The objectives, first, what I'll do is go over some recent research findings. Then I'll talk just a little bit about some of the patient management and clinical recommendation guidelines put out by ASRM. Then I'll talk for a little bit just about patient concerns and different patient pattern presentations that I'm seeing at the clinic currently. And then I'll conclude with some coping strategies that I implement with patients and that can easily be implemented by others as well. Next slide. I think this topic of talking about the emotional impact due to COVID-19 is really timely as well as relevant. We've all been exposed to, been experiencing, and been impacted by this pandemic thus far. Like, I think it's safe to say that we've all had some anxiety and some fear in regards to the unknown, especially at the beginning of the pandemic. No one really knew what this was going to look like, what to expect. We've all been faced with being isolated from our loved ones, from our colleagues, friends, and family. So I think we've all been impacted by this. But I do think there are some additional considerations that now that we're in the middle of it, that we need to consider now that we're about to move forward with it. One of those being we're approaching the fall and winter flu season, and we're already starting to see spikes in the numbers. And I think that has got a lot of people really worried and very afraid of sort of what's to come. Like what you mentioned, Dr. Sipe, we're like, this is the 9th month that we're in this, and I think a lot of us are just kind of tired of it. We've reached the maximum in terms of our ability to cope, if you will, and we're just all tired and not really knowing what's next. Not only did we deal with the fear of the unknown in the beginning during the COVID pandemic when it first started, but I think what a lot of people are dealing with now is fear of what is known. Many people, they have seen the deaths, they've known people that were infected with COVID, they've witnessed it. You hear on the news stories where one person in a home gets it and the entire home is sick and they're in the hospital, and people have lost loved ones. So I think people are now really afraid of what this looks like, and they're really afraid of the fear of what they know and what this looks like. So I think we're seeing a lot more of that being discussed. There's also this mentality amongst a lot of people of, if it's my time to go, then it's my time. So I think that's also contributing to possible spikes where people just feel like, if it's meant to be and this is the way that I'm supposed to go, then this is the way that I'm supposed to go. So we're seeing less people taking those necessary precautions due to this sense of, if it's time, then it's time. We also need to give some consideration to the stigma that is involved with COVID-19. For a lot of people, there's stigma, there's embarrassment. They don't want others to know that they've been infected. They might live in environments where this is stigmatized and they would be ostracized. I think many of us were putting hope towards the development of a vaccine, and I think that's great. But for a lot of people, that doesn't necessarily give a sense of hope because they aren't even sure if that's the appropriate thing that they're wanting to do, if you will. So I think these are all really important thoughts and considerations that we need to give thought to now that we're going forward with this and looking at the next phase. Next slide. What I'll do now is just talk really about some important studies that I think were relevant and worth noting in this presentation. Next slide. The first study that I'll talk about looked at the emotional impact of the ASRM guidelines on patients when COVID-19 first started. And I thought this was a really interesting and an important study to note because this really impacted fertility patients specifically. One of the recommendations put out by the society was for new cycles to be halted or not started. And this particular study really assessed what patients thought and what they felt in regards to those guidelines. And up to half of the half of the participants, they had a canceled cycle. And those patients that had their canceled cycle, close to 90%, they found that to be almost extremely upsetting. 22% rated that cancellation as the equivalent to the loss of a child, and a little bit over half, they made the report that if they were given the opportunity to start that cycle in consultation with their physician, then they would have. I thought that was just really interesting information looking at what patients felt when it came to that guideline coming out. Next slide. Instead of doing a lot with the numbers in terms of the rates of patients that were feeling anxiety and distress, I thought that it was more interesting to focus really on what specifically were patients really concerned with when it came to COVID-19. The first study that's at the top, this was a study that was done out of Australia, really looking at the most popular parenting blog that was in Australia, and they essentially looked at what were the themes that patients and parents were most concerned with at the time. And a couple themes that were expressed were a lot of people felt a lot of fear and concern with the external environment. They really weren't sure what to do when it came to if their kids needed to go back to school. They were afraid of going to the supermarket, just really kind of engaging with the external environment. That was one of the main stressors. They also talked about a lot of grief and sadness in regards to their inability to interact with individuals in their life, their friends, their family. They were missing this interaction with family in terms of being able to respond to the support that would have been given with their interactions with friends as well as families. A lot of patients, they reported guilt in regards to wanting to move forward in their pregnancy attempts, kind of in the midst of all of the stressors that were going on with the pandemic. They also really talked about their fear and their sadness when it came to needing to postpone their attempts at pregnancy. This next study looked at the concerns that obstetricians said patients most contacted them for. And you can see based on those numbers, most patients were concerned with if when they needed to go to have their child, if that they would be safe within the medical center setting. They were also really concerned with methods of protection. They were concerned about if their child would be safe They also talked about their anxieties in relation to messages online and sort of information that they were gathering online, as well as being concerned with their exposure and their being infected with the COVID-19 virus. Next slide. I think it's not only important to look at the impact of COVID-19 on patients, but I think it's important to also look at the impact when it comes to staff that work in this field. This particular study was a meta-analysis looking at the rates of anxiety, mood disorders, as well as insomnia on nurses and doctors. You can see there that the rates, they're pretty consistent with what's found in the normal population. But I thought that it was good to include this particular study because this found that women tended to report levels that were greater than men, and nurses tended to and report levels that were greater than doctors. So I think based on some studies that are more recent, that pattern is still existing. So I thought that was just interesting to note. Next slide. This slide is busy, but I thought that it was important and key. This really looked more at the assessment of what was important to doctors, nurses, and individuals that work in healthcare, excuse me, just in terms of what they needed. And it's like, if you look at the slide, it's busy, but I've sort of tried to put on the left those things that were most important and that were most noted. And it was essentially that people want to make sure that they're being cared for, that they're being heard, that they're being trained in a way that's appropriate, and that they're being supported by the medical centers that they're working for. So I thought this graph was worth noting and really interesting, just in regards to laying out what staff were most concerned with and what they wanted most in terms of their expressing need. Next slide. This was an interesting study that was done. It was basically a combination of a lot of individuals that work within this field, looking at different theories that were important to take into consideration when it comes to creating plans of coping with the COVID-19 pandemic. And I think it was really interesting in that it's important that we all step back and look at a lot of different factors that might be influencing the way that we all cope with the COVID-19 pandemic, but especially patients. And that's taking into account the individual way that we all look at our threat, risk perception when it comes to COVID, looking at the culture in which we individually identify with, and just looking at a lot of factors at both the personal level as well as the cultural level that might be impacting the coping strategies that we all individually utilize to cope with the pandemic. Next slide. Based really on that research, there were some guidelines put out by ASRM, both and for patients as well as for medical and providers. When it comes to patients, a lot of those recommendations are listed here, and I'll just go over a few of them. But one of them was to be a powerful influence when it comes to your interactions with patients, making sure that you're giving them information that's reliable and up to date, really emphasizing more of a kindness and pro-social approach when it comes to their dealing with the COVID pandemic. Next slide. And then there were some recommendations made for providers as well as staff, and that really just really started to emphasize the importance of making sure that you are providing the appropriate resources for staff, and that you're monitoring for any burnout or for any work overload. You're emphasizing the importance of taking care of yourselves. Make sure that you're able to both work well with patients as well as work well with colleagues, if you will, and that you create a good atmosphere of positivity within the work environment. Next slide. So I thought now is a good time to talk really about a few of the patient concerns that I see at the clinic currently. Next slide. These are a lot of the different ways that this COVID-19 pandemic has impacted us all, but I put in the darker color a few of the ones that I see most commonly when it comes to patients at the clinic. A lot of patients tell me that they're struggling with this swing within their mood state, where they're calm one minute and they're extremely distressed and they're upset the next minute, and not really knowing what to do with these constant mood swings. They also come in with lots of experiences of anxiety and mood disorder, changes in sleep. I see a lot of patients talking about their response to COVID-19 as being very different than what they thought they would have personally done to deal with this kind of stressor. Another thing that I see with couples is one person might be responding in a completely different way than their partner. I have a lot of couples where one partner wants to maybe pause treatment because they're really afraid that trying to attempt that now puts their entire household at increased risk that they might not be comfortable with, whereas the other partner wants to move forward in treatment. So I talk with a lot of couples kind of dealing with what do we do when we have such different reactions to the pandemic and this possible threat, if you will. So I see a lot of couples that are dealing with kind of ups and downs in regards to their management of the pandemic and the threat, if you will. Next slide. So now I thought that it would be good to talk about some coping strategies that I utilize with patients in session. One being this method of trying to focus really on breath. With most patients that I talk to, what I try to encourage them is to focus on their breath kind of in general, that during the day, just try and take a minute or two to just kind of focus on your breath, not really utilizing one technique really over the other, but just really trying to take a breath in as well as out and do that over and over. But I do talk with patients that tell me that they can't really focus really on their breath because their thoughts are constantly swirling. So with those patients, and I try and implement this particular method called the box breathing method. The reason that this one differs from just taking breaths in and out is this one, it really allows you to stay present in the moment by taking a breath in, then you hold, take a breath out, and then you hold. This is good because it makes patients think really about what they're doing. So if a patient tells me that they're struggling with maintaining their breath or maintaining the ability to calm down, then I'll oftentimes implement this one because it forces you to think more than just focusing solely on your breathing in and out. So this one is really good for patients that are just struggling with managing obsessive thoughts, where they can't really step back to just simply do work with their breath in general. Next slide. A lot of patients that I've been talking to in regards to managing the stressors that come along with COVID, the way they tell me that they're suffering sounds very much like a mild panic attack. So this is one of the techniques that I like to use with patients that tell me that they feel like they can't breathe, that their heart's sort of racing, that they're panicking. This is a really great technique because it forces the individual to stay in the present, and that's one of the keys when it comes to managing that level of anxiety. What I'll really encourage patients to do is when they're feeling that, or if they feel that level of panic coming on, to really pay attention to the environment that they're in. This particular coping strategy, first what you want to do is you want to encourage the patient to try and identify 5 different things that they can currently see. Then you want to tell them to identify 4 different things that they can touch, and you go down this list to things that they can hear, things that they can taste, and then things that they can smell. This is a really effective technique when patients are experiencing any sort of panic-like or panic attack-like response, because they mentally get distracted by what you're encouraging them to pay attention to, and their anxiety level starts to lower after that. When I've encouraged patients to implement this, they always come back to me later and say this is probably one of the most effective strategies that they've utilized, particularly when it comes to managing panic in the moment, and it's really easy to implement and to instruct with patients. Next slide. This is another really effective strategy. I think we are all living with a baseline level of stress now, like that's been increased, and a lot of us were at the point where we don't even know that our minds and our bodies are essentially stressed. And what I have a lot of patients tell me is they're so tense that they don't really know what it's like to not feel that tension anymore, because their body is just constantly in a state of stress and tension. So this is a good strategy to essentially use. It's basically where you encourage patients to tense certain muscle groups and then to relax that muscle group. This is a strategy that's really effective because by intentionally tensing and relaxing those muscle groups, it allows you to identify what it feels like when a muscle group is tensed versus relaxed. This is effective because over time, if you do this more often, you can better recognize when your muscles and your body is in a tense state, and you can better identify that state, and then you can relax that muscle group. This is another strategy that I have a lot of patients tell me is really effective, because they weren't even really aware that their body felt that tension and stress, and that it was trying to keep that as a baseline level. So this is another strategy that's really accessible. It doesn't take much practice to really become good at it, and I think patients really enjoy this one also. Next slide. And then this is something that I have been encouraging patients just to do. I think it's a good slide. It's very basic, but to manage this particular pandemic that we're going to, what I tend to tell patients is to focus on these main things. Keep a routine, make sure that you're reaching out to loved ones, and take some time to personally step back and reflect on your own goals. Try to maintain a sense of positivity and some sense of optimism, given all of the stressors that are going on. And I think this is also really effective because it's basic and it's simple, and a lot of patients really respond to these 3 R's when it comes to coping during the pandemic. Next slide. And that's it. Thank you. I hope this was effective in giving you some presentation of what I'm seeing currently in the clinic, some coping strategies, and what the research literature says.
Dr. Edwards, that was excellent. Thank you. I'm hoping to start some of those breathing techniques, but I am the person who can't get some of those thoughts out of my mind. For me personally, I am I'm a father of 4 kids, teenagers down to grade school. I am a busy practitioner with a great number of patients who are wonderful and need my attention. Married with a wife who is wonderful and needs my attention. I'm practice director, and so my practice needs my attention. And then there's the pandemic on top of that needs constant attention. So it's like having another child, but one that's unruly, and you can't really, it's not really stopping, which is what makes it sort of a challenge. And I think as a health practitioner, you knew it wasn't going to be over at this time of year. You knew when it sort of kicked in, it was going to be a long-term kind of a thing. But you were hoping that it would be a little bit calmer. I will tell you, as I reflect on the whole pandemic, I'm very happy it wasn't as serious as it was seeming to be back in March and February and March. I mean, seemed like we were all really going down the tubes. So, it's a lot better state now. I know all the infection rates are going up, but the mortality is not as high as it was back then, because I think we've learned a lot about the disease. I do think the pandemic fatigue is there. I've seen it, with even in certain social circles. I've seen it with certain clinicians. I've definitely seen it with our patient population. And it becomes a little bit of not a little bit of a challenge, a big challenge. We've had, one of our goals at FCI is, because what we do is technically elective. It is a disease, and it's not something that someone brought onto themselves typically, but it doesn't make a huge difference if they delay something by 1 month in their overall pregnancy outcomes. It can increase their anxiety by just waiting 1 more month, but the actual prognosis of what they undergo is not going to be challenged by waiting 1 month. And so that's why we took a practice approach to try and screen out COVID patients, because simply waiting, the 37 days for the maximal virus shedding, or the average of 20 days. And our policy is, if you've tested positive for 20 days, we don't want to have you back for, 21 days. And that seems to be, there wasn't a ton of data when we came up with that, but I'm glad to see there's some data to support it now, Kevin. So thank you. And it's really trying to set the table. And I think every infertility doctor does this, and all doctors do this, but we sort of get the benefit of seeing a patient before they get pregnant, is to make sure everything is as optimized as possible for our patients, as much as you can control, and then really hoping for the best. And I think that's part of the challenge that every physician is facing. We've seen a huge healthcare burnout even at our local clinic, and it's interesting because as some of our staff leave, they're being replaced by people who are coming from hospitals who had a huge burnout from being at the hospital. And it's actually, when I talk to all my colleagues who are hospital-based versus clinic-based, they're seeing the same thing. All the clinic staff are going to the hospital, and all the hospital staff's going to the clinic. It's just sort of everyone's moving, these different directions. So we know healthcare workers are feeling, a lot of stress, not just the ones in the hospitals, but also ones doing clinic and not even caring for COVID patients. So it's definitely challenging times. So thank you. All right, well, I think this has been an excellent, update on October 20th, 2020, as far as, where we sort of stand from a pandemic standpoint. I think it's very reassuring to hear that it doesn't seem to be transmitted in semen. It can impact the testicles, which thereby can impact sperm numbers. It doesn't seem to be in an egg transmission pattern. There doesn't seem to be any transmission between couples having intercourse, as far as any study that I have seen. And getting pregnant doesn't seem to be impacted by any negative means. And then once someone is pregnant, there is a little bit more risk to the pregnant woman sort of later on. Kevin, one thing you did not touch on, which there's been a couple of random, everything's sort of random with COVID, but a couple of articles that have suggested that there's a slightly higher rate of miscarriages in the first trimester. I don't know if you've had a chance to review those articles. We've seen I think there's only 2. They're not very big, but we've seen those. I don't know if you're able to comment on that.
I haven't reviewed it in depth, to be honest, but here's, always my hesitancy in any particularly early literature assessment, and particularly of miscarriage rates, right, is that selection bias, in the sense that being such a common normal reproductive event, that when we're monitoring patients closer, we detect more miscarriages. So it's not been so astounding that that I'm that convinced that there's an independently higher risk of miscarriage. That would be in the absence of severe maternal illness, right? But for a mild case, I'm not convinced that risk is markedly elevated. And I think I think where we're really going to get a lot more useful information are from the registries, right? Where we can prospectively follow these people, particularly for that type of question. I think that's one that is a very important question, but I think we can only get a real sense of the data by looking at it prospectively.
Yeah, as clinicians who see recurrent pregnancy loss and pregnancy losses with, in the general population with a 20-25% natural incidence that's accepted, you know, it's hard to see a huge delta sort of in changing that and pushing it one direction or the other. Although it is interesting, if there is a vasculitis pathway to this, that, you know, there is some literature, you know, that does support some autoimmune, vascular autoimmune disease, cell membrane autoimmune diseases, and some blood clotting diseases that do cause a slightly higher rate of miscarriages. So it's going to be interesting to sort of see how that plays out. Personally, I have not had a patient who got pregnant and then miscarried. You know, for us, as I mentioned, we're screening out COVID positive people, and we're stopping their treatment. So it is possible that they get COVID between, you know, when they have a transfer, when they have an IUI, and when they become pregnant. But we have not seen that very frequently, thank goodness. There were a bunch of questions sent about vaccines, and I'm going to sort of tackle that one a little bit. As of right now, there is no vaccine anywhere in the world that is being readily used. I do believe that the Russian president did come out and say that there is a vaccine that they are using. However, I have not seen anyone else in the world jump onto that bandwagon, so I'm not going to put a ton of faith into that discussion. You know, there are obviously different political factions and different physicians are saying different things about vaccines. I think on many levels, they're both right. You know, if you look at how long it normally takes to make a vaccine, you know, we're talking years and years and years, no, not like 6 months. And the fact that we are in stage 3 trials now for a vaccine, and, you know, I think it's one of the 5 major vaccines group has gone to a phase 3. I think that speaks volumes over what really is being pushed by every health expert and everyone in medicine. I think everyone recognizes that the vaccine is really the only way to decrease transmission, you know, short-term and long-term, and protect as many people as possible. I was always surprised to see that the federal government just bought 10 million vials of vaccine that doesn't exist yet, and I didn't quite understand why. And some of my pharma folks did help me understand that. And it's an interesting concept. So essentially the federal government in this case, would go buy the vaccine that doesn't exist to help fund the research to those companies to do it. And then it also, if it's trying to show promise, to start mass manufacturing that vaccine before it receives, you know, whether we're calling it preliminary or FDA approval for distribution, there will already be some vaccine available. So the dollars that are spent are spent more on the research side of things, as well as spent on the pre-production of the release of the vaccine. So when they say, hey, we've got a vaccine, there may already be 10 to 20 million vials that are already made. So when somebody might say there's vaccine going to be readily available, on one level, they're sort of right. On the second level, it's not one that's necessarily available yet, but it could be, you know, once it passes a phase 3 trial. From the best estimates, talking to pharma and the, you know, MPH folks and the epidemiologists and some family that works at the CDC, I would expect the earliest that we would have a vaccine would be January. And even then, it's a little unclear how effective that vaccine will be. You know, one of the things I think all of us, you know, touched on was antibody testing. And I think everyone sort of touched on it and moved on because no one's really knows whether that's important or not at this point. There was, I don't know if the study is actually published, but I saw a pre-release article on 25 reinfected people with COVID. And these are people who they were actually, from the majority of them, able to compare the different strains they were infected with from infection number 1 to infection number 2. And they did identify it was 2 different strains of COVID, SARS virus. It wasn't the same one. And it seems to be that if you get infected the second time, that gives you a much worse course of action and worse health course. So the vaccine, you know, I think even if you've had it before, could potentially prevent a second strain that impacts you. And, you know, there's a lot of epidemiologists who think that this is going to be as common as the flu moving forward, and it's just going to sort of be circulating around with us for a very long time. And so you'll get your flu vaccines and your coronavirus vaccines at the same time, which, that's the way the world works. There's a lot of people in the world. There's a lot of viruses that get transmitted. And although it's not travel, if there wasn't travel, it would have not necessarily escaped out of the Asian population to the different states. I don't know if anyone else has heard anything on vaccines. If you please share.
Sure, if I can make a few comments. Some of to speak to Dr. Edwards, I don't want to have a overly optimistic view in this context. Those two seem contradictory, but on many fronts, I've been sharing with my patients some optimistic points. And I think even with my children, I've shared an important point, which is as medical scientists ourselves, I think that putting all of the divisiveness in the politics aside, I think we can be proud as a world about the triumph of science. And I hope that science will maintain an important part in the public discourse as a result of this. So facts being that within a week of this, we identified it was a coronavirus, right? The scientific community, that is. Within another week, we had the sequence to this virus. And very soon thereafter, vaccine development was undertaken. That's astounding. And I really hope that when we all recover physically, psychologically from this, we will look back at this historically as a real triumph for science. The techniques that are being utilized, novel techniques for vaccine development, are why and again, not to be overly optimistic, why I think it won't take years. The other sad part is, the reason why it won't take years is we still have too much virus circulating. So that's why these phase 3 trials we're gonna get results, because we have a lot of virus circulating to determine whether they're working. But some of the small trials that I've seen that have come out, I think most are working against that spike protein. And I've just been increasingly encouraged by some primate data where they were given test vaccines before these phase 3 trials and exposed to coronavirus, and they demonstrated neutralizing antibodies that bound a virus and seemed to prevent replication. That's pretty astounding and exciting. So I feel, and this is, I think looking at some of our public health officials as well, that I want to maintain confidence that we will have an effective vaccine. And as you pointed out, Dr. Sipe, the deployment is going to be the challenge. And it is I think the other good side, nonpartisan side of this as well, utilization of government funds toward ramping up production pre-trial is unique and interesting, but also a very important insurance policy. That's how I view it. I view that as just like we want to put an insurance policy in different parts of the public for economic stability, we also want to do that in this world. I think in India as well, there's some large manufacturers that have supported pre-production of vaccine in order to let it out of the gates right away, particularly for our higher risk citizens. The elderly, I would think, would be high risk healthcare providers as well, as important propagators of disease. But as far as antibodies go as well, I'll comment on that briefly if you wish. And by no means am I an infectious disease expert, but I've talked to our director of infectious disease quite a bit, who's quite useful in our group. And I am advocating, I do assess SARS-CoV-2 antibody status on patients who've had infection in the past. Some of it might be, I rarely like to do fishing expeditions with lab studies, but I have done it here. It goes hand in hand with, of course, it's not a passport, an immunity passport, as we say, but still reinfections, I'm confident they've been reported, they're there, but they're still relatively uncommon. I think the big question why I think it might be useful to assess that is whether waning immunity is there. All the patients I've assessed have had positive antibodies. I did just assess someone, though, who had an infection just prior to pregnancy, and she was pretty far along. And interestingly, she had a negative antibody test. So I have to wonder whether her immunity wanes. So I think that might provide useful to us. The other thing that we've utilized when we talk about cessation of precautions, because we initially were utilizing 2 negative screens, which seemed far too restrictive, as you well know. So symptoms and a symptom-based strategy is really what we're utilizing with our practices, patients who have the 10 days from symptom onset and fever-free. But But in those patients, in patients who might have had lingering virus, when you have those patients who seroconvert and have antibody, when they demonstrate seroconversion with SARS-CoV-2 antibodies, we have good reason to believe that they might not be actively infectious as well.
Mhm.
So I find that can sometimes be somewhat useful.
There's some, in talking to some of the other infectious disease docs that I've interacted with, they feel that we're probably going to find a tighter level, that when you order the antibody, you're going to look for some specific level above which you are immune, below which you are not. They seem to correlate it a bit with severity of disease. So if you are a very ill person, you're much more likely to be having a very robust immune response, and thereby generating a good antibody, load, versus someone who may be asymptomatic or have very, very mild symptoms. And so, they said they don't know where the line's going to be, but they're pretty convinced that that's where it's going to be. But there will be a line somewhere that we sort of feel safety is going to be important. One of the questions that was purported was asking about when to give the vaccine. Now the vaccine doesn't exist, so I don't know that we can really give advice on something that doesn't exist yet. It's not a live attenuated virus that they're doing, so it theoretically should be safe in pregnancy once we verify that there's no side effects and other things that could potentially happen. But as opposed to like getting a rubella vaccine, you don't want to do that in pregnancy because it's a live attenuated virus. But it does seem like it's something safer to do. So I don't know that we can answer any of the questions on vaccines. Is it safe to do in pregnancy, pre-pregnancy? Should I do it before I start my infertility treatments or decide to get pregnant? There's no real answers to those unless someone else has something else that they've heard of. But everything I've heard of, it's not live attenuated.
The one thing to highlight, though, is that there has been a clear absence of pregnant women from these trials. And so when I talk to my patients and they ask, well, when the vaccine will be, and then when could I use it in pregnancy? Unfortunately, this is not the first time or only time that pregnancy might be at the back of the line, but pregnant women will not be the first or the second to be vaccinated as we consider how this will be applied to the population at large. I think the way I would phrase it to my patients, if a vaccine comes to be, hopefully you will benefit for the majority of others to be vaccinated. I just think that's something to highlight because there still is an absence of studying this uniquely in pregnant women, which we all would want before we would start to distribute it.
I agree wholeheartly and agree with the absence of data there. Children too, right?
Right.
I think that's the other concern is that, but this is what customarily happens with anything new and evolving is that we have our risk-averse populations, children and pregnancy are the top of that list. But I agree clinically, it certainly makes sense that it should be safe, but being a risk-averse time, I think that we would want to benefit from population vaccination first, and then hopefully we can have those trials. But I have to believe that that's going to be a third, fourth tier study, or some that happen anecdotally, right? The inadvertent vaccination that occurs when we do have a vaccine, and then following those patients moving forward.
Yeah, definitely. One of the things that I think everyone also touched on was telehealth. Telehealth was in its infancy stage about a year ago. And in fact, in 2020, codes were actually created, nationally to use telehealth. Now it was not really endorsed well by any insurance company. It essentially wasn't even paid by most insurance companies. And now, unfortunately, I guess it's a positive thing to come out of the pandemic is that most states' laws said you have to cover telehealth just like you would cover some type of in-person visit. Because one of the things we saw very early on is people stopped going to the doctor for routine care, for screening, for anything. And so a lot of diabetes and other illnesses just went rampant without anyone, controlling. And so the ability to do telehealth, to make patients feel comfortable, to make staff feel comfortable has been really paramount for health professionals to continue to administer care in the middle of a pandemic. I know that we have been, watching, especially in Illinois, what Blue Cross Blue Shield says, and they say, hey, we'll cover telehealth until the end of 2020. And United Healthcare likes to wait right up until 2 days before they say they're going to stop to then add it again. So it'll be interesting to see what happens with telehealth moving forward. I think every medical practice has figured out a way to do it, whether it's Zooming like we are now, whether it's doing some other go to meetings or some proprietary telehealth product that your EMR may use. I think it's here to stay. Obviously there's procedures that have to happen. So for us, aspirating eggs, doing inseminations, doing salines, doing deliveries, doing amnios, CVSs, all those things have to be obviously in person and physical, but a lot of routine things you may be able to do just simply, via the telehealth. And I was glad to see Dr. Ohlander showing data that it actually saves patients money. That doesn't mean it saves the practices any money, but it saves the patients money from lost wages more than anything else. So I don't know if you guys have seen telehealth, where you think it's going and where it is, but.
We developed, one of the earliest we developed in our group at the start of the pandemic was a so-called alternative prenatal care structure. So prenatal care is an interesting ritual that has developed not with a lot of evidence or science, but it's somewhat ritualized in its approach. And as I've said to my group many times, I think that this might, the remnant of our alternative prenatal care structure with less in-person visits actually can be quite a positive into 2021, 2022 for professional women who often will disrupt their busy workday to come for a prenatal visit, which is a relatively brief visit of limited value. And so I think that that's a positive that can come through it, either through a telehealth visit or even all creative things like a home blood pressure cuff at home and a fetal heart rate monitor to assess those two important things that we pretty much assess at a prenatal visit. And truly, I can see that as the cost savings to women. And even from our economic standpoint, prenatal care is a bundled cost. So ironically, in the obstetric world, that would actually be cost savings because you'd have more time in your office to see other patients, right. not a routine prenatal patient who it's such a, it can be such a disruption.
Right.
From the male side of things too, it's great in the sense that the female partner can be a part of the conversation. It's who's able to be in the room for evaluations. These guys that we're bringing in because we want to be able to do a physical examination. If their partner's not allowed to be in that visit with them, a lot of these guys they need that information from the female, telling them what's been done, where they're at, things along those lines. And the female wants to, or I should just say the partner wants to know that information as well. So I think that helps a ton from that standpoint.
Yeah, I would agree, because a lot of times the notes I receive from you are not exactly what the spouse tells me is going on. And so sometimes I have to piece it together and, I email you if there's an issue. They always hear what Dr. Madsen has to say. They always are, I know what he said, here's what he said, and it's always the same because that's the woman hearing everything and driving that bus. But the guys, we tend to be a little bit more, you say something? I don't know.
Yeah, there's a lot of holes that need to be filled in.
Correct. Well, I don't know if there's any other questions or any other topics people wanted to talk about, but I thank the panel for coming together tonight. I'm sorry, this was a little bit longer than we had expected, but there's a lot of great information in every presentation we had. So thank you very much. It is October 20, 2020. And as I said, on October 21st, there might be something new that comes out, which would be wonderful. Hopefully it's in the positive direction. So we'll see where that takes us, but thank you very much.